Tēnā koutou katoa, kia koutou te mana o tēnei whenua, tēnā koutou katoa. I tau mai ana tātou ki runga I te karanga o tēnei rā. Ko te hāora he kaupapa nui tēnei kia tātou katoa. Nō reira he honore nui tēnei ka tuahau ki mua ia koutou I tēnei wahi I tēnei wā. Just by way of saying, it's a great, very important topic. Thank you very much for asking me to speak and acknowledging the original people of this land. Thank you. So I want to acknowledge the people and the places and who've informed my work, and in particular the children and families that I've seen in my clinical practice. And I'd like to congratulate the Asthma Foundation on three marvellous pieces of work, three marvellous publications: the impact of respiratory disease, to which I'll refer in some detail, the health literacy report, which is very impressive and informative, and Te Hāora, which has just been launched. So I do congratulate the Asthma Foundation on its proactivity in providing these most marvellous and important resources for now and for the future. Where do I point for this to get the change? Where do I point? Just there? Right, okay. So I was asked to talk about the National Respiratory Strategy in regard to the two diseases. So this won't be a particularly clinical talk, it'll be bringing it back to the strategy. So I want to acknowledge Emilita Bourne, who was 2 years old when she died in August 2014, and this case was publicised widely through the media when the coroner found that a cold, damp house contributed to her death from pneumonia. In fact, the house was a state house. Here it is shown here. I just want to tell you briefly about pneumonia for those of you who don't know much about it. This diagram of the lungs shows that an area of infected lung, an infected lung is pneumonia, and that's where there's bacteria or viruses and a lot of inflammatory cells, and the lung, which is normally full of air, becomes quite solid, and not only are you sick from the infection, but you also may suffer from lack of oxygen, especially if that infected area of the lung, the pneumonia, is more generalised, which it often is in the most sick children. So that's what pneumonia is. Deep infection in the lungs. Most commonly caused by a virus or bacterium, and these are found in situations of more commonly in situations of poor environment. Now I'm just going to show you a video of bronchiolitis. This is a child with bronchiolitis, and a baby with pneumonia will look exactly the same as this to a layperson, or to apart from the fact that this baby here has got wheezing, which is what distinguishes bronchiolitis from pneumonia. And what I want you to see is the effort that the child is putting in to breathe with every breath, and how the child is clearly not feeling well, is irritable, and the baby is breathing fast. So now I'm hoping I can, with the assistance of my person there, I can... Okay, so that's a baby with bronchiolitis, and this is caused most commonly by a virus, the RSV virus, and it starts with a cold. It might cause a cold in an adult, but in a baby it can cause this kind of serious chest infection. So pneumonia and bronchiolitis are the bread and butter of the most commonest, so pneumonia, bronchiolitis and asthma are the three commonest reasons for children to come into hospital in New Zealand, and our rates of these admissions are way higher than many other comparable countries. So we do have a big problem with these diseases being very common, and I'm going to illustrate some of the data and then talk to you a bit more about the environmental factors which are picking up the themes in Te Hāora. So the data we can get from the Asthma Foundation's Impact of Respiratory Disease in New Zealand report, which included 4 diseases relating to children and also COPD in adults. So we've already heard a lot at this conference yesterday on asthma and some today, this morning on bronchiectasis, and now I'm talking about childhood bronchiolitis and pneumonia. But the themes I'm going to talk about and the data I'm going to show for bronchiolitis and pneumonia, read really any of these other diseases. The magnitude of the differences may be different, but the general themes are the same. So childhood pneumonia hospitalisations per 100,000 children per year from 2000 to 2013. This data from the impact report. And you'll see here a graph which is fairly stable and starting to go down a bit. If I tell you that our rates here for hospitalisation are about 5 times those in the United States, it will illustrate how the level of this is way higher than it really should be. It's great that the rate of hospitalisation is starting to go down, and this is probably related to the introduction of the pneumococcal vaccine. And you can see it's making some impact, but not very much. So about 25% reduction. So we can do some things about diseases by using vaccines. While childhood pneumonia is very, very important, or many reasons why it's extremely important, and one of them is that it can lead to bronchiectasis, and we've heard a lot of that today. So our high rates of bronchiectasis in New Zealand are related to our high rates of pneumonia. Now, and this is illustrated here, really, where we see childhood pneumonia hospitalisations by ethnic group. And you'll see how disparate the rates are, with Maori much higher than Asian and non-Maori Pacific Asian, and Pacific even much higher still. Quite similar to the bronchiectasis rates we saw that Cash showed. Big ethnic disparities. And if we look at deprivation, this isn't by ethnicity, but just the poorer circumstances, which are the 7 to 8, and particularly the 9 to 10 deprivation index there, you'll see how incredibly great the hospitalisation rate is in those socioeconomically deprived neighbourhoods compared to the rest of the country. So we've got very big disparities here. There were 110 childhood pneumonia deaths in New Zealand from 2000 to 2011, and by my reckoning, that's about 10 a year. 10 children a year died from pneumonia in New Zealand. That's way too many. That's 10 too many each year. We shouldn't have any deaths from pneumonia in New Zealand, but we do. And you'll see that the rates are stable, not going down. Very disturbingly, the distribution of these deaths by ethnic group is even more extreme than that for hospitalisations. As you can see here, Pacifica death rate are roughly 6 times non-Māori Pacifica Asian, and Māori only slightly behind. Very disturbing ethnic disparities. And this is showing by deprivation as well. So I'm just wanting to illustrate here that if we wanted to do something about childhood pneumonia in New Zealand, we have to do something to lift children who are in socioeconomically disadvantaged circumstances, and Maori and Pacifica, who of course are disproportionately found in those groups, but independent of that. We've got to do something to help their health. We meaning us and the country. So this data shows that that's where we need to put our energies. Now, coming to childhood bronchiolitis, there, mercifully, deaths are rare compared to pneumonia, about 1/10 of the rate of deaths. And you can see here the death rates actually are going down in New Zealand, with no deaths reported in 2011. So that it's a source of relief, but not of complacency. This is just not such a lethal disease. It's a disease that makes children very sick, as you saw in the video, and you'll see here that in contrast to the pneumonia rates, which can be affected by the vaccine, we have no vaccine for bronchiolitis, and you'll see here that the rates of hospitalisation are actually going up. Is there any evidence that we're admitting children to hospital more commonly for less severe disease in New Zealand to account for this? No. So this is a real rate increase, not due to diagnostic transfer or lower threshold for admission, but it's a real finding and of great concern, because for bronchiolitis to have that many and to get that severe requiring hospitalisation means that something must be wrong in the environments. If we look here by ethnic group, and we'll see a similar pattern, although more extreme even, than for childhood pneumonia, with Māori and Pacific very affected. And in fact, we're still, a lot more research needs to be done in this area, but it's quite possible, contrary to international opinion, it's quite possible that some cases of bronchiolitis, indeed, may go on to bronchiectasis. So this burden of serious lower respiratory tract disease in New Zealand is very high, and it's disproportionately affecting our Māori and Pacifica and more disadvantaged families here, as you can see this extreme picture here. So, we've got a big problem, and we've got a marvellous call to action. And I would like to congratulate in particular Kathy Leese, who's been the author of this report, and I think it is a marvellous achievement. And this is where the positive, this is, as Cass said, this is the positive. We have a way forward to reduce the incidence of respiratory disease and to reduce the impact of respiratory disease and eliminate inequalities in respiratory health in New Zealand. Much of this, as Cass said about bronchiectasis, is preventable or treatable. There's lots we can do. And in this document, as you probably heard yesterday, we have po ora, which was framed by Mason Jury, around haora, toi ora, whānau ora, and Maori ora. And these are the things we need to attend to if we go into the areas in which actions need to take place. And there are 4 key issues that Te Haora identifies where we need to take action. And I think we all here today are concerned in all these areas and involved in all of these areas. But I'm going to focus on only the first for the remainder of this talk. So the very words in Te Taiao, the environment, in the section of Te Haora, was to work to eliminate poverty, improve access to affordable, warm, dry, uncrowded homes, accelerate efforts towards smoke-free Aotearoa 2025, and to tackle obesity. We've had a wonderful talk about that just now. So I'm going to address each of these points in turn. And of course, you probably do know that I've been a long-term member of the Child Poverty Action Group, and I'm going to spend a bit of time to start off with talking about incomes as a basis for poverty. So this shows you the data from New Zealand on poverty, and this is children versus the whole population from 1982 to 2013. This is using an income measure which is less than 60% of the median disposable income after housing costs, and it basically says, however the whole population's doing, we're going to relate these figures to the whole population, to who's above and below midpoint. And we see by this measure, which is well accepted internationally and used widely in New Zealand, and this is the MSD, Ministry of Social Development's own data, you'll see that we've got more children in poverty than we have the whole population, which means disproportionately more children in poverty. And there's a big change, and that you might not be able to read the year, but it was in 1991. Between 1991 and 1992, there was a big change, a huge increase in the proportion of people in poverty, and this affected children more than adults. If I had more time, I'd have a bit of a quiz on this, but I'm going to give you the answer. What's caused that change? And it was the 1991 budget where they slashed the level of income support benefits for families by 21%. Did they slash the level of income support benefits for the elderly at that time? They were going to, but the elderly voted, and it was political suicide to slash it for the elderly, so they did not slash it for the elderly. But children can't vote, and they were disproportionately affected. You'll see there's been little change in poverty levels since then because there's been no measures taken to significantly improve the incomes of families on benefits. You can measure poverty by income, you can measure it by what there isn't in the house, and by this measure, there's about 180,000 Kiwi kids going without the things they need, which is warmth, food, and clothing, as illustrated here. And other things too, like being able to afford to go to the doctor and have a meal made and stuff like that. So by this data, 17%, about 1 in 5 of our children are not getting the basics in their home for their basic needs. This here, of course, all this material is going to be available, I think, on your website, so you can, but this is data from the MSD again, and just putting some figures here on different ways you can measure poverty in New Zealand. And these are, again, internationally recognised measures. And so the income poverty the one I showed you in the graph is about 1 in 4 children in poverty, because there's 1 million children in New Zealand, and about a quarter of those are in poverty by that measure. Take a harder line, it's about 1 in 5, 200,000 children. Material hardship, it's 180,000 children. If you combine the worst of the worst, it's still about 10% of our children, about 100,000 children. That is truly shocking, to have that many children struggling for their basic well-being in New Zealand. And of course, this directly affects their health, as you know, and I'll allude to further. I'm just wanting to illustrate, I don't think people do know, people who work at the workplace, we know how bad things are, but I wanted to illustrate how bad things are for families on benefits compared to other New Zealanders. Now, looking at this graph here, you'll see that there's 3 lines. One is the average wage earner, which is the top blue line. The next one is New Zealand Super, which is the black line. And the green one is what was then called the DPB, Domestic Purposes Benefit, plus family assistance with 1 child in the family. I think the things you'll note from this are in 1991, the green line plummeted by 21%, and it's hardly changed since then at all, hardly changed. You'll notice that the NZ Super tracks up relentlessly with wages. Why is that? Because not only was the Super not cut in 1991, but since then it's been, by law, has to track wages. It can never fall below 60% of wages, so it always goes up. So now, if we look at the income support benefits paid by our government to our people, more than half of them go to the elderly. So we have a very paradoxical situation in New Zealand where we give the older people appropriate support and we deprive families on benefits of enough support. Worse than that, these diseases that I have shown you, childhood pneumonia and bronchiolitis, most commonly affect children under the age of 12 months. But we're particularly mean to families with babies in New Zealand compared to Australia. Australia has a terrific policy to support babies in the first year of life, to give enough income support. They give a baby bonus. Their policies are transformatively better than ours. But parents, if you've got a baby, 1/4 of our babies are supported by a benefit, and those parents do not get paid parental leave, 7,000 a year for that would be. They do not get the in-works tax credit, another 3,000, that adds together as 10,000 odd. And they also don't get the parental tax credit. So we are depriving the most disadvantaged families who are having babies of the absolutely essential income they need to make ends meet. So are we surprised we have such high rates of admission for respiratory disease in New Zealand of the most deprived, economically deprived percentage of the population? We can't be surprised. This is, if you like, this is inevitable if we treat our youngest citizens like this. I have to say, this is very little known about, and I myself didn't know about it till about 18 months ago, and I learnt about it from Susan St John and Child Poverty Action Group. So please promulgate this information. People think that improving paid parental leave is going to be the best thing for New Zealand families. And it will be great for those families, but what about all the kids on benefits and insecure income? They're still getting nothing. Those are the ones who need our money most. And so just to summarise how we're treating children compared to adults, we have this paradox where for the older adults, and I have to say, a month or so ago, I crossed over the bar, and I'm now a superannuitant. I have a super gold card, even though I'm earning a bloody fortune. And, so look how we treat the older people, and look how we treat our families. We stigmatise them as beneficiaries, and we penalise them for being in that situation. This is a disgrace. Sorry, there was one thing I wanted to show you on this. The All Blacks are topical today. Where do you think the All Blacks' income is on this slide? For each individual All Black, their incomes are way up here, and we laud them appropriately for their achievements. But those achievements have been built by the huge incomes that they achieve as professional footballers. So let's just have a think about how we celebrate success in New Zealand. We can laud those extremely high income earning All Blacks. I heard that Dan Carter's taking a $3 million per year job in Paris next, and how we treat our beneficiaries, our future citizens. And is this a fair society? Yeah, moving on. That's all I'm going to say. I'll probably go and watch them in the parade as well. So here are, just look, I'm going to finish by, I'm going to rattle through these last slides. There's some important policy steps to reduce poverty, and I can go into detail, but the basic thing is we need to raise incomes to an adequate level for all families supported by income support benefits and those in low-paid work. 40% of our kids in poverty are supported by a person in full-time work. So it's not just about beneficiary families, but unhealthy housing. I'm going to flick through this so I've got time for some questions. Unhealthy housing is a huge issue. And we also know there aren't enough houses, and now houses for some families are garages, like the one on the top, or even a vehicle. Both of these sets of families thought their children were getting sick, respiratory illnesses because of where they lived. I'm sure they're quite right. How does unhealthy housing cause health problems? I've got these listed here. I refer you to the Child Poverty Action Group website, where I have written, with others, frequently asked questions about housing and health. So I refer you there if you want to know more about this issue in more depth. And does making New Zealand homes healthy improve health? The answer is yes, by several studies done in New Zealand, including particularly Philip Howden Chapman in Wellington area. So it makes no sense that we should do something about our unhealthy housing. We need a warrant of fitness for all rental properties, private, state and social housing, subsidies to improve the quality of private rentals, because it's hard to get for all landlords to get them up to scratch quickly, which is what we need to do. We need to rapidly increase the number of state houses and social housing, not decrease them. And we actually haven't even had a discussion about creating state emergency housing. We have no such thing in New Zealand. That's why we've got 2,000 families waiting, as we speak, on priority A of the Housing New Zealand waiting list, which actually means they need immediate housing, and that number's static. Okay, so I've covered briefly some steps around poverty. There's things we can do tomorrow if we choose to around housing, the steps we can take tomorrow if we choose to. And the other 2 points were smoke-free and obesity. So let's just look at those. We made it, thanks to Tariana Turia, in 2011, we made a policy that New Zealand would be smoke-free by 2025, and I'm putting a question mark there because I don't think our rate of change is enough to achieve that. Smoke-free means that less than 5% of the population is smoking. And I know that was one of Esther's dreams, that we'd have fewer people smoking in New Zealand, and I'd just like to acknowledge her in that way and all the other wonderful ways, of course, we've heard about. But we are making very slow progress towards this goal, and it's great that our smoking rates are going down. We have good policies in New Zealand that we need to make them stronger, faster. And then policy steps to reduce obesity. We'll have a range of views about that, but it's all very well to say people can make their own choices. Can a 4-year-old child make their own choices about what they eat? Can a 3-year-old, can a 2-year-old, can a 7-year-old, can an 8-year-old? You know, we need to have public health measures here, not just individual choice. And my paediatric dentist friend, Katie Bates, said she just doesn't think it's right to say a 4-year-old with rotting teeth has had a choice about whether drinking Coke or not. You know, obviously the parents have made a choice, but that child has no choice. So the sorts of things we might be thinking about, of course, are no sugary drinks in schools and only healthy food sold in schools, and a sugar tax for soft drinks. And please go and look at this link. It's an inspirational story from Mexico that's just come out in The Guardian that shows, despite untold pressure from the sugar industry to not have a sugar tax introduced in Mexico, it suddenly came in, and the sales of sugary drinks have gone down 17%. So, you know, people say there's no evidence that sugar taxes work. The problem is hardly any countries in the world have got them, and this is one piece of evidence that at least they're reducing the intake of those drinks. Now, I'm wanting to finish with something food for thought. So this shows you the graph I showed you before on childhood pneumonia deaths by ethnic group, and remember I said there was about 10 per year, so most of those will be Maori and Pacifica children, obviously from this data. I'm wanting you just to take that graph in your mind, and now I'm going to just change it a bit. And I'm going to show you here childhood pneumonia deaths, the hypothetical rates by ethnic group, and I've changed the ethnicity groupings here so that the highest group of deaths are among European children and the lowest among Māori and Pacifica. And I want to ask you to think about, in New Zealand, would more be done about childhood pneumonia deaths if the majority of them were were European? If the majority were European, would more be done? Question. So I want you to think about that, and I've thought about that a lot, and I think if the answer is yes, then we know we've got a problem with racism in our country, and it may not be witting, it may be unwitting, it's the history of our socialisation, and speaking as a New Zealand European, 5 generations, I've had to self-reflect on this issue. And I would like to, before I go further, I would like to applaud the Asthma Foundation and for the lead you've taken on addressing equity issues for Māori and Pacifica, evident in this conference, evident in all your publications, and I think that the Asthma Foundation is showing a bold lead on these issues and has done for some time, and so I'd like to congratulate you for this work, and we have to, you know, we're leading by example and showing courage, and mahi a te mahi, we've got work to do. Fiona Cram put it another way about the potential that Pākehā children have life experiences like biking with the wind behind them, whereas Māori children, their life experiences may be like biking into the wind. Surely we should make it an easy ride for all our kids. So as part of my learning, I want to share with you, and this is my final slide, my own learning over the last, over the last decades, but particularly in the last year or two, thinking about this issue. And this title here is actually that of Rhys Jones, who's a senior lecturer in Māori health at the Te Kupenga Hauora Māori at the University of Auckland. And he gave us a wonderful talk with that title, and I'm referring to it on the slide, which is the first link there, which you can obviously look up, or I can give to you. It's a recorded paediatric update talk he gave in March 2014. And I found it very inspiring because it made, in a gentle way, he asked us to look at ourselves. And that question of our society, our health systems, ourself, myself, are part of the problem. And he posed us this vision that we can be part of the solution through transformative change, including the effects of colonisation and racism on ourselves, of which I personally have had. That is my whānau life experience. So it's something I can work on. And I'd like to also refer you to, very much so, to the very last link there. In July 2014, the Ministry of Health published a wonderful document which is so brief and easy to look at. It's 2 A4 pages. And it's the Equity for Healthcare Maori framework. And I urge all of you who haven't yet looked at it to look at it. It's terribly easy to look at. And it gives us a template to follow. And I think that it came out with little fanfare and little there was no big media release about it or anything, but it's there on the website and it's just such a good document. And again, it gives us a framework to start to look at how we can change and how we can influence not only ourselves, but also the group with which we work, and the institution with which we work, and the system with which we work, and the country in which we are, and so on. And as Cass knows, our team at Starship, we've started to look at that framework for our team as just a beginning. And all I'm saying is I feel that these two for me have been a start of a new beginning for me to look at this myself and where I work. So thank you very much. Good on.
We have time for a few questions from Ines. One over there.
Yeah? Well, you told me where to look. Okay, right.
Thank you. Thank you, Professor, for your presentation. I Pacific, I'm Samoan, living in Palmerston North, have been for 32 years. Now, Palmerston North could not be compared to Auckland and Wellington. I find it so disheartening. The statistics, have never changed. But nevertheless, my approach is that we all have a job to do. And we must be connected, starting from, the DHBs, the local city councils, the general practice teams, the support workers in the community, WINS, Housing New Zealand. We should all be connected to wrap these families around. And I think we should go further than from what we see at Starship or what we see in general practice teams and go out, because I think if we reach out further, we will be able to help more. And I always believe that New Zealand health system has always provided the best for all New Zealanders, regardless whether you're Māori or Pacific. Maybe there are, but on the whole, it is a good service. So thank you.
Kia ora, thanks very much.
Thank you, Ines, for addressing an issue that I totally agree as health professionals, we all should be addressing the whole area of equity, especially in respiratory health. My question to you is address the issue of poverty and environment and obesity. What about the role of education? I mean, should we not be, one of the things we know is that if we are going to address this issue of poverty, the cycle of poverty, should we not be doing it through working in partnership with education? And I'd like your thoughts on that.
I couldn't agree more. Time didn't allow for me to go into education, and it's certainly a big part of this. And of course, it's a big part of the health literacy. So education in its general sense is extremely important, and of course in its specific ways in learning about health. So unfortunately, poverty can stunt your chances of educational success, and if you've read the New Zealand Herald, and probably most of you haven't, but this week they've had a great publicity about the incredible inequities in education in New Zealand, and what they call the long tail of underachievement has got longer, and our education minister underplays that. But it's a great concern that I've shown you the health disparities, and the education disparities are equally great. And there's so I think that there are many excellent reports and groups who can show the ways to change this, but I don't think we certainly can't change it only by dealing with education. And so to me, it's a group. To me, the key issues, the very key issues, and sorry I didn't sort of make a fuller picture, but they are all in here, are poverty, unhealthy housing, inadequate access to basic healthcare and education, which sort of intertwines all of those, and it's linked with all of those. So you're absolutely right. Thank you for the comment. Yeah.
Can you hear me? Yeah, that's better. There's several points I want to talk about with your fantastic presentation. Thank you. I was just thinking also, with regards to the Plunkett system and the maternal health stage, you're going from, like for example, when I had my children 25, 27 years ago, it was just coming out that you could go home, within 12 hours after having your child, you could go home. It was when I was doing my nursing training that people stayed in hospital for 4, 5, 7 days to get their motherhood skills up to gear and before they went home with that child. If we still did that with our young mothers of today, I still wonder if we would have more chance. I don't know what the maternity system's like now with education of the mothers in the home, but if we had them actually still within the maternity hospital, if we were educating young mums and making sure they had all these skills up to gear before they went home, would we have less health crises with our children of today? No. Moving on to the next thing about the disparities between the European...
Can I just take one at a time? My memory's not so good. So can I just take each part of your question as it comes through?
Yep.
Otherwise I won't be able to remember.
Mm-hmm.
So I totally agree with you, and I think if you take generally speaking, if you take something away that seems to be good, you need to replace it with something. So I think the key element here is that brand new mothers need a lot of support for things to go well. Now, that could be provided in hospital, it could be provided at home, providing there is the support there. I've just pointed out to you that 25% of our babies that are suffering from extreme economic disadvantage, those newborns, and they might be in very unhealthy homes. So it would make a lot of sense to start off a bit longer in hospital. But even if they're in an unhealthy home, they need health visitors or whānau supporting them properly. So what they need is support, and I think there is notwithstanding the rhetoric, there is from many of our politicians that the first bit of life is really important. The fact of what's been delivered by New Zealand society to very new families or new babies is the opposite of that. So we need to advocate for more strengthening of the support to brand new mothers, yes. And that is in a range of ways: physical and economic, and housing, the whole lot.
Yes.
Thank you. Education.
Yeah. Yes, I totally agree with that. With the bronchiolitis, for example, just one of those basics that came out in your training was making sure, are the young mums airing their mattresses? Are they getting a new mattress one per child type
Do they have a mattress?
Do they have a mattress?
Yes.
Are they sleeping them in their own beds? Are they, with their mattresses, are they airing them every day with so much moisture pumped into those mattresses each day by a child with wet nappies and breathing and so forth? Are they making sure they're aired and mould and dust free and so forth? Those types of things at that young age, carrying on through now with I deal with my parents' my respiratory patients 16 years and older, but I still bring that message home to my respiratory patients about making sure what I call bedroom hygiene, aired mattresses, new pillows, vacuum around under the bed. Those basic principles are really, key for respiratory health. Also, I do believe...
I do agree with that, thank you.
Yes, totally. The basics are necessary. Also, I don't believe, with regards the European versus the PI Māori, that there's a discrepancy with the health there. If you turned it on, it's your hypothetical issue. I just see that there's a massive hole in paediatric health because the paediatrics can't speak for themselves. Paediatric health, full stop, does not get all the funding, quite frankly, be it respiratory, be it cardiac, so forth. That's what I see. That's my personal...
Yeah, thanks very much. I think that there is underfunding of services for children. I agree with you there. I think we'll probably be able to take another question from somebody else wants
I'm
to.
being a pain. 26 million should go to new houses and clean houses to improve our health, full stop. Thank you
very much.
Thank you. Any more questions? Well, thank you very much, Ines. We'll ask Lou to.
As I was listening to Ines' presentation, I'm scribbling as well. So I'm going to sing to you. This lady actually features in the history of the Asthma Foundation. A lot of you may not know that, but she does. Here it is. Ines, thank you for your kōrero, the links you made to our own te haora. Ines, thank you for your kōrero, your passion is clear. As you embrace our strategy. Ines, thank you for your kōrero, your solution challenge. We will take away from here. Ines, thank you, thank you, thank you.
Wait one moment.
I think Lou has really popped up in a very, very lovely way. But yes, just on behalf of us all here, just your inspiration, your emotional approach to this, and you get in there and do it. I mean, food, health and warmth isn't a lot to ask for, and I think we need to seriously look at what we do and how we do it. So thank you very, very much for highlighting it.
Thank you so much. I'm so moved. And I would just say the Asthma Foundation is inspirational in leading the way on this. So there's no limit. Take inspiration from Esther and her parents speaking this morning. There's no limit to what is achievable if the Asthma Foundation wants to show the way. Thank you.